Good afternoon, everybody. Thank you very much for joining us on this National Greener Practice lunchtime meeting hosted by Greener Practice Gloucestershire. So my name is Wendy Tyler-Batt and I'm Chair of Greener Practice Gloucestershire and also one of the directors of Greener Practice. So before I hand over to our speaker today, Dr. Ben Lees, I just wanted to say a few words about Greener Practice for anyone who's not in the know. So Greener Practice is a not-for-profit community interest company enabling primary care to become more environmentally sustainable. So we do this through our network, working in partnership with individuals and organisations that share our values, and through our Greener Practice platform. So if you haven't visited our website, do please take a look. It's a great way to make connections through sign up to the local WhatsApp group and national special interest groups. All this receiving national and local newsletters, and some of our resources are free. There are in excess of 50 off-the-shelf QI projects and more resources behind a modest paywall. And so these can provide you with evidence for multiple CQC standards and other quality improvement standards, including medicines optimization and safety, which not only contribute to environmental sustainability, but save you time and money. It also helps to complete many of the Green Impact for Health toolkit actions, which Greener Practice have just taken over the running of this this platform in partnership with the Royal College of General Practitioners. And Green Impact for Health, as probably many of you know, is a great framework for a whole team approach to chart your sustainability progress in general practice. And a significant proportion of our Gloucestershire practices are signed up and have received awards. Going back to the Greener Practice platform, there are 3 levels of membership, or 2 levels really. The network basic, which is free for all the things that I previously mentioned, and then the network plus, which you can join as an individual, or even better, get your organisation to join, which allows you full access to all the quibs, and it is pretty modest at £30 a year. And there is a QR code there for you to join to find more information. But if you just put in greenerpractice.com into Google, you will find us. So, and just to mention that the information that's shared today is accurate to the best of our knowledge and is to inform and educate and not a substitute for clinical judgment. So we really would like you to, at the end, fill in this, give us some feedback, and Ben's got a feedback thing as well, and we'll show this slide then again. So over to Ben now, who is going to probably introduce himself, but he is a GP partner at one of our Gloucestershire practices and has been there since 2015. But notably, he was the first, well, he's a founder member and the first chair of Greener Practice Gloucestershire. But he's moved on from sustainability into AI, another big world problem. So over to you, Ben, and I will stop sharing my screen.
Thanks, Wendy. Just for the tech trouble now, let me make sure that you can see. I've never been very good at this sharing presentations bit.
Or just to say while you're doing that, Ben, that we encourage you to put things in the chat, and we want it to be an interactive session, and we'll have some time for Q&A at the end, we hope. Okay.
Okay, great. There we go. Can I just check, can everyone see my slides?
Yeah, that's good.
Okay, I've yet to figure out how to do that clever thing where, you know, you have the face in the corner to present to everyone. I don't know how to do it. So anyway, just thank you everyone for coming. I'm really touched that so many people have turned out, actually. Wendy, thank you for the kind introductions. As you say, I'm a full-time GP partner in Gloucestershire. I do all the kind of usual clinic work that all GPs do. I look after a care home as well, so that's sort of part of my week. Lots of elderly folk with lots of dementia. And I'm also a GP trainer, and I do some mentoring for colleagues on the Spark programme. Hang on, there we go. Sorry, wrong slide. And as Wendy said, yeah, I took on a fellowship first back in 2020, and I was really interested at the time in how we can make primary care more sustainable and start to kind of, I just couldn't stand all the waste around us, and it felt like nobody was doing anything in the county about this. And so I got involved and launched, well, along with a select few people, of whom Wendy was one, got the Gloucestershire Greener Practice group up and running, which is now doing fabulous work. And I suppose the really important thing to say here is that I'm not a sort of tech evangelist. I'm not being paid by Anthropic or anything like that. And I don't really like AI, if I'm quite honest. I'm not here to sort of sell it to everyone. I think it's quite terrifying. It's exciting and terrifying in equal measure. But what I'm doing this year is to try and do a bit of digging into how we're implementing it in primary care and how we can do that more safely and how we can help people like you and I, GPs and people working in general practice, how we can use it without kind of coming croppers, really. There we go. That's who I am. I wanted to hear a little bit from everyone at the front end of the talk about what you would like to get out of this. So I'd be really keen just for people to pipe up with maybe questions they've got about AI in their work. If there's any burning issues, please get them out now, and I'll try and make sure that we cover them as best we can. So if people just want to shout out or pop something in the chat, Wendy, I hope you can see the chat because I can't.
Yeah, I can see the chat and I can feel that. But yeah, people just to take this is a very, very casual session, relaxed session. So do just take yourself off mute and chip.
Yeah, please do just chip in.
Venus got something from the chat. My questions are about the climate impact and water and also data. I'm very concerned about the NHS's use of patient data, especially with all the data breaches, Palantir, Biobank, patient leaks.
Yeah.
So,
yeah, there's, I mean, really, really valid concerns,
yeah.
Lena. We'll definitely talk a bit about the climate impact. I've got a little section on that, so we'll come to that.
And she's, yeah, go on, carry on.
Yes.
Yeah, and we'll talk a bit about safety and kind of keeping your data safe and things. Absolutely.
Environmental costs versus gains from Marion. Vina's also saying, so using AI widely, and I saw there was an announcement about widespread rollout of Microsoft Copilot, which has 0 out of 100 on ethical consumer. I suppose one of the things I might just chip in with is like, you don't have the option to turn it off sometimes. You just, it's just there, isn't it? You put in something to the search engine and it's just automatically uses AI. How to gain proper patient consent. Can IA help us become more efficient and use fewer resources, which is obviously the plus side of it? How can we limit the climate impact using AI? How can we use AI wisely but reducing climate impact? From Claudia. The environmental impacts. Climate impact is obviously a big feature, unsurprisingly, that people want to know about. So.
Super. Well, okay. I think we will cover most of those things, but please do, if please do put your hand up or sort of shout out of the things that come as we go along that you want me to maybe try and talk about in more detail. Like I say, I won't know everything, but I'll do my best to pass on what I do know. Richard, you've still got a hand up there.
Yeah.
Oh, yeah. Sorry, I just want to chip in. I was about to tell everybody what was going on in Gloucester County Council. We're having a big deep dive into all that stuff, the ethics, the climate impacts, but also what's worrying is, especially with this has come out of Palantir as well, what Palantir is doing elsewhere, and that a lot of these companies are American companies, and what's going on in Europe. So a lot of councils and everything and health services in Europe are using alternative European sourced and based AI platforms which don't involve American companies, which I think is is where we're going to be pushing for at the GCC, because a lot of them there are alternatives, and you can choose ones that have better kind of ethical standards, really. Just want to chip that in.
Yeah, that's really interesting, Richard. It's not something I know much about, the sort of alternatives to what's in place at the minute, but I can definitely see real arguments for this stuff to be looked at. Okay. Well, look, I'll move on. Thank you all for sort of contributing there. I want to talk briefly about what I use in practice, and I'm going to try and keep it simple. I'm a great player, and kind of I figure things out by getting tools on board and going and mucking about with them in far too. It infuriates my wife. But I'm trying to keep it simple. I'll not get into all sorts of tools that aren't relevant. Microsoft Copilot, like you say, is embedded in 365, so we all have access to it through your nhs.net subscription, and we use it at my practice for everything from drafting communications, summarizing documents, writing up policy templates, and some of the kind of back office stuff that just eats up people's time. It is very helpful. We also use Heidi, which is one of those voice transcription tools, ambient voice transcription. So Heidi listens during a consultation and generates a summary consultation note that you can copy and paste into the clinical record. There are other products out there, but we went with Heidi for various reasons. Accurix do a very similar product called Accurix Scribe that other people might come across. There's other big ones like Tortoise out there. I find it, I'll come back to it, but it's helpful and not helpful at the same time. And I kind of swing between, I love this, why have I not used this more, to, oh my God, I hate this, so shall I just cancel my subscription tomorrow? I really am quite ambivalent about Heidi. But what I want to talk about is bringing these tools into practice was not straightforward. It took quite a lot of work at the information governance end with myself and my practice manager before you can really start using these things, especially things like Heidi. So Copilot, I believe you can start using tomorrow, as long as you're sensible, because it's coming from nhs.net and it's come through all the approved channels. Something like Heidi or an ambient voice transcription tool, you've got to go and make sure you're happy with the data processing agreements. Where's this data going? What's it being used for? They must have MHRA registration, and they need to be approved as medical devices, as class 1 medical devices. Now, I'm not sure how I feel about that. Class 1 medical devices, a box of gloves is a class 1 medical device. So something that doesn't directly influence decision making or patient care is a class 1 medical device. Really something that I would argue that by listening to consultations and summarizing and pulling things together, actually these tools do influence patient care by taking a play and writing the notes. So I think there's a real argument that actually the class 1 registration, which is very, very easy to obtain, is not enough. Obviously, any new tool, you have to have these data protection impact assessments in place, and the Heidi gave us their DPIA, and we had the help of the IG leads at the ICB. The ICO, sorry, the ICB. I trip up over my acronyms, there's too many of them. To kind of sign that side off and make sure that they were happy with it. We had to work out what to do if patients don't want us to use it. Are we going to ask patients every time if it's okay to record the consultation? And actually we do that. We explicitly check with them that it's okay to to do that. And we've advertised in our waiting room quite clearly and on our website that we're using these transcription tools. And ultimately, patients have the right to opt out. They have the right to say no. I've not had a patient decline yet, but they do have the right to do that. But this took work, is what I'm saying. This took real work from an IG lead in a practice. And then we had to sit down with the team and we had to talk about these tools, and we had to talk about how to use them safely. We had to talk about when not to use them. And that took meetings with our team as well. So, the vendors want you to think it's all very, very straightforward, but actually it takes work to implement these things. But your IG leads or the ICO at the ICB can be really helpful in getting these things through. I want to talk a little bit about where I think AI can genuinely be helpful and where it might, or where I see it coming in the future, but it isn't quite there yet. So we talked about voice transcription. I think that's a really, really interesting use, because that was kind of the first thing that I really saw, where I really saw benefit and saving on my time from an AI tool was having a tool listen to the consultation and write the clinic note. And at first I thought, oh, this is fabulous. And I was convinced I was going home maybe an hour earlier every day because of it. And as time went on, something didn't feel right. And I realized that I was doing all this work to try and make the templates create notes that are like my notes, but it doesn't do it. No matter how hard you kick the thing, the notes that come out are not as good as an experienced clinician's notes. And there's something about, I think doctors do, and I'm sorry to be a bit doctor-centric, I know we have an MDT here, but I think clinicians, I should say, do a bit of their thinking and processing time while they're writing their notes. And you lose that when software writes your notes. And then we almost leave little breadcrumbs for our team and for our own brains afterwards to pick up from our notes. And we're used to looking at our old notes and picking up where we left off. And again, I just found I was losing that. So a patient would come back for a follow-up and I just couldn't place myself in the old consultation. And then one of the big sales points of the vendors is, oh, you can spend less time talking to your computer and more time looking to your patient and talking to your patient. I think my consultations actually start to take longer because my patients thought they were there for a nice old chinwag. Whereas when I'm sort of got one eye on the computer and I'm kind of, hopping back and forth between the patient and the computer, I think it instills a sense of urgency almost. And it reminds the patient that it's a medical consultation and it's not a nice long counselling session. So I'm really ambivalent about the real time savings with ambient transcription. But I would say this is for people to use and experiment and see what works for them. Referral letters, I think there's a genuine time saving with referral letters where it listens to a consultation and then will write you a referral letter in a matter of seconds. That's lovely. But actually what I've started to do, instead of recording the consultation, if I want to write a referral letter, I will just load up Heidi.
Sarah Dutton at the library about the meeting tomorrow.
Yeah.
Oh, hello. Sorry, we've got a bit of interference there. So what I tried doing next was actually just talking in bullet points, or talking like I would talk to you about a referral letter. So I would say, look, Heidi, we've just seen my patient and, is 38 years old and she's got a, I don't know, left-sided inguinal hernia and I just want the colorectal surgeon to see her, please. Would you write me a quick letter? And Heidi would just write me a nice letter. And actually for complex referral letters, that's lovely because you just kind of chat about what's just happened and it'll write a really nice letter. So I found that a really useful function. We talked a bit about admin and governance. and its use in kind of drafting policies. I find AI really helpful, for Copilot, a really helpful research tool. So you can tell it what you want it to go and find out, and you can tell it where to look. So for instance, yesterday I wanted to know something about practices, obligations for frailty and palliative care meetings. And I said to Copilot, go and look at the CQC guidance, look at the GMS contract, look at various places where it might find good practice, and come back and tell me, what does my practice actually have to do with regards to having frailty and palliative care meetings? And it was great. It was great. It was like having a sort of a good intern go and do the research for me, and it came back with answers that probably would have taken me a good hour of digging through documents in a matter of 5-10 minutes of chatting with it. Where do I think it could go? I think it could start to summarize our records really well. We don't really have the interoperability with our clinical systems yet to let this happen. So you can't get a record on your System 1 or your EMIS and say, look, just summarize all this patient's health complaints for me. But that's not far off, and I think it will be really helpful when it starts to work with System 1 and EMIS on that level. I see real benefits for drug interaction screening as well. So AI potentially looking at patients' prescription meds and telling us when it spots problems. And I think that will really benefit pharmacists and doctors and patients. But again, we need that interoperability, and we're not there at the moment. And then decision support is much more controversial. That's where AI might actually start to, maybe it'll start off with listening to a consultation, and then maybe it'll start to have some input into what's actually been said, and maybe what it thinks could be wrong with the patient, and where we should look for guidance, how we should treat that patient. And I think that's quite a worrying thing. That's a really worrying thing. But I think it will go there in the future. I mean, thinking of this is changing so fast. Give us a few years, and we'll be in a very different landscape. Okay, I want to talk about where AI falls down, and this is something in previous talks I've had a lot of questions about. So, again, please do hand up or pipe up if there are things that really matter to you about this. A lot of people ask me, well, what are AI hallucinations? Hallucinations are essentially where our AI makes stuff up. They're an integral part of, an unavoidable part of how AI models work. These large language models, they're not like a brain that looks at a problem like you or I would. They are trained on huge amounts of written material, basically the whole internet. And they use that to work out, well, if this word has been in a sentence and this word's been in a sentence followed by this word, what's the probability of the next word being this? What's the most likely next word? And what that means is that it gives answers that feel like sensible answers. But if it's decided based on its sort of language bingo that the next most likely word is something that is complete nonsense, it will give it to you with total confidence. And it's very easy to be sucked in by this stuff and to read its answers and to think that it's right. So you've really got to, I think in clinical work, you've really got to check your sources and ask it for sources. Say, you've suggested this thing. Where have you got that information from? Where's the guideline you're referring to? Let's go back and double check that guideline. Let's look at that guideline before we make a decision about this patient. That's a very clinical way of looking at it. But whatever you're asking it, ask it for sources and go and check the sources, because it might be talking absolute nonsense. It also, because of the way it works, it can't judge. It's not capable of judgment. it's funny, like you hear people saying thank you to their AI because they're afraid that, you know, one day it's going to kind of take over the world. And if you've not been nice to it, it doesn't care. It doesn't have feelings or judgment or any of those things that we think that that we imagine it might. So don't ask it to judge things. Don't ask it to make decisions because it can't do it. Ask it to give you information so that you can make a decision. But don't ask it to judge things. But if you ask it to judge stuff, it will do it because it wants, I'll say it, they're trained to give you answers that it thinks you want. Okay? So if you ask it to make a judgment, it will appear to make a sensible judgment. But that's because that's how it's been trained to act. But it's not really capable at the back end of making judgments. Same gut feelings, safeguarding. And this is why I think there will always be a job for doctors and clinicians. I don't think AI will take our jobs. I think we do too much nuanced thinking, and I don't think computers will ever be able to take that off us. Thank goodness. A word about bias. AI also underperforms on minority groups because they're trained on data that reflects historical inequalities. So certain groups of people are more greatly represented on the internet than other groups. So don't assume that it's performing fairly across your whole population. Okay, that's enough about what it does badly, I think. The real key message of this slide is remember that AI is not accountable. So if you make a decision based on AI information, it's not a defense ever to say, well, the AI told me so. Actually, the AI can give you as much bad advice as it wants. It's not liable for that advice. We're liable for the decisions we take and the recommendations and advice we give to people. We're reliable. So if the AI gets it wrong, it's on you. Okay. Now, moving on. Question at the beginning about data and safe use of AI. I mean, just no patient identifiable information ever to go into ChatGPT or Copilot or Gemini. So no patient names, no patient dates of birth. No. Even the NHS Copilot, I am very wary of. In theory, the NHS Copilot isn't used to, if you use your NHS Copilot license to query something, that shouldn't ever be used to train the wider Copilot model. But I don't trust it. And I recommend you don't as well. And then if you to go outside of the NHS models or the NHS kind of endorsed Copilot, if you go onto your ChatGPT models or your Geminis or your Claudes or whatever, it's a wild west out there, guys. And if you put patient identifiable information in there, I mean, God knows where it'll end up or what it could be used to do. So just no, don't do it. We talked about owning the AI output. We've covered that already. Really, you're responsible for the outputs, not the AI. Prompt injection attacks. I don't know if anyone's heard of those, but they're a really scary concept that I came across recently. A prompt injection attack is where a document or can be as simple as an email contains hidden instructions that will make an AI act differently to how it's intended. So, for instance, your Copilot is very easily tuned into, it's not many clicks to have it do things like review all of your inboxes and things like that. And there have been past incidences of major security leaks with, as I say, malicious emails being read by that AI and basically hijacking it. There's nothing you can do about it except to be very careful of any files or information you're feeding into AI. If you're going to give it access to emails or put documents into it, make sure you're happy with them. Make sure they're safe and robust. You're putting stuff in that's come from weird places that you can't vouch for. Okay. Moving on. Right, environmental cost, which I know people were interested in talking about. This is really interesting. I just looked into this for this talk, actually. Now, okay, a lot of big numbers, like with all climate reporting, a lot of big numbers that can be hard to get your head around. But every time you use a tool, you're essentially using energy. You're consuming water. You're drawing on a physical infrastructure, the data centers, the cooling systems, the power grids that are driving these tools, and it has real environmental footprint. Now, tech companies don't declare their footprints. It's fascinating. They're really cagey about it. There've been some good research done by reputable places like Stanford University, starting to look into this. And some of the figures I came up with from their research was that already this year, we're estimating up to 80 million tons of CO2 from AI. Now, that's, for context, that's about 20% of the UK's entire carbon output, or the equivalent of all of our cars being driven for all of our UK cars being driven for 2 years. That's massive. Water, maybe 765 billion litres, or 300,000 Olympic swimming pools in a year. And electricity, again, really tough to estimate, but we think maybe AI data centers consuming about 4 times all UK household electricity combined. Just think about that. 4 times the UK's household electricity consumption being burned on AI in a year. And it's growing. So current estimates I read were that by 2030, that might be more like 9 times the UK electricity, or the UK domestic electricity consumption. And these data centers, I don't know if anyone's seen what data centers are like, but they're horrible. They're these big sort of faceless, noisy buildings that produce sort of 70, 80 decibels to the surrounding environment, which is equivalent to it's like having a motorway driving past you or running past your home. And a large data center can use as much water as a town, about 50% of Cheltenham. I was going to say a town of, sorry, we're not all Gloucestershire, are we? So maybe that doesn't mean much, but a town of 50,000 people anyway. That's how much water can go through a data center in a year. And
Ben,
lots of these sensors. Yeah.
Can I just chip in, Ben? Because there's a very pertinent question here. So Katrina's asking, is this from your data here that of the environmental cost? Is it from one source for us to quote? We'd be quite interested to have that. So
a lot of it is coming from. I don't have them to hand, but
no,
if you're interested,
we can catch up
Katrina,
afterwards. So yeah.
I could send you my documents that I've got it from. A lot of it was from that big Stanford study that I went through. Yeah, I've got a couple of really interesting documents on it. Happy to share them.
Thank you. Thanks.
Where were we? Okay, so it's big use, okay, a big footprint. And the more we use AI, the more we're driving the growth of these data centers. Now, companies are quite secretive about it. And let's see. And researchers are trying to estimate using things like grid data and corporate sustainability reports and published modeling, what's actually going on here. The companies won't really release the information that's needed. They report things like company-wide electricity use or total water use, but they won't report on the indirect water, so the water that's used by the power stations to create all the electricity to power the data centers. And that can be sort of 3 to 4 times more water than is actually going through cooling in the data center itself. But they don't report AI-specific energy consumption. They don't report per query carbon or water costs. And they don't report on how much of their infrastructure is dedicated to AI workloads. So it's all a bit foggy. It's really foggy. And I just don't think that's okay. You know, in healthcare, we're always, from day one, we're taught that you need information to make informed decisions, and these companies aren't releasing this information. They're not being held to that standard. So I think there's a real issue there for government and for regulation. Okay. Now, so all the gloom and doom about the environmental impact of this stuff aside, I personally feel it's really worth keeping in perspective the different uses and asking ourselves, look, is this a good use of AI or not, given that it uses a little bit of resource each time we do. Things like voice transcription, it's actually got quite a small consumption of AI resource each time it happens. And if you were to say, look, maybe voice transcription tools are saving clinicians half an hour or an hour a day, and reducing the risk of burnout and maybe helping them put more appointments on, then I think the AI, the impact, the footprint of that AI use is probably justified. If it was drug interaction screening, and again, it's probably relatively low cost in terms of data center use, and potentially you're going to keep patients out of hospital for drug errors or avoid hospital admissions and things, which have a really big environmental footprint. It's probably a good idea to do that stuff. But what makes me really annoyed is when you see all these kind of just AI nonsense use. You see AI being used as like, I've started to use a chatbot because just to talk to, because I didn't want to go and talk to a real person, or endless sort of iterations of silly caricatures for people to put on their LinkedIn profiles. That carries a footprint, it carries a use, and it's a wasted resource. So I really think we need to start asking ourselves, and everybody needs to start asking themselves, is this a good use of AI? Okay. Gosh, time is marching on, isn't it? I want to leave time for some questions at the end. So yeah, I think judicious use of AI is what matters here. Is there a real problem that we're trying to fix? Is there another way we can do it? How would I do it if I couldn't use it? If I couldn't use AI? Can I just write my own clinical notes, for instance, as I am probably doing 75% of the time at the minute? Does it create some sort of social good or some sort of good for my workplace or my patients? One interesting point that I want to make to everyone is that when you look on an AI tool like Copilot or ChatGPT, it will offer you different models, and it will say things like, do you want to use GPT 3.5 or GPT 4 or GPT 4.5? I don't know, I'm making up the numbers of them, but and the sort of assumption is that the latest model is going to give you a better answer. And those more high-powered models use vastly more computing power than the earlier, simpler models. And actually, if you're getting a good enough answer out of a simpler model, go with that, because it uses less resource. It uses less electricity, less water. But people don't want that because they see the thing that says, "Oh, do you want this model? It's the best one," and they use it. But try the lower powers, guys. It's fine. They're often really good. And don't use it recreationally. So, let's get people to stop using it to make silly, like, nonsense images. Sorry if I sound boring there. Okay. What do people need to do? I think tech companies need to face up to their environmental responsibilities and start disclosing the emissions of this stuff. We can make a big difference by where we site data centers. So actually putting them in suitable places can make a huge difference. Places where there's ready supplies of water, not in the middle of the desert. One figure I read is that the environmental impact of these things, I think it was the carbon footprint and the water use, can be reduced by 75 to 80%, depending on placement of a data center. And the ones we build today are going to be the ones that we're using for the next decade plus. So people, they need to be sited in sensible places, and hopefully powered by renewable energy. Regulators, I think, need to hold these companies to account and make sure that they report what they're doing. And actually, I think the NHS, that was a really interesting question at the beginning about how Copilot was rated 0% by ethical consumer. I didn't know that. I'd be fascinated to know what was behind that. But it's concerning, isn't it, that the NHS has clearly bought into this massive model from Microsoft that it sounds like is raising real ethical concerns there. Doesn't surprise me in the slightest. Okay. And just to say, this is going to grow and grow, guys. But I want to move on to questions, okay? So we're at about past now. Let's cut to questions. My summary points really. Yeah, sorry.
No, you carry on with your summary points. I was going to say I'll go through the chat before. Go on. Do you want to do your summary points first?
Yeah, sure. Really, my summary of the whole thing. Like I say, I'm no expert on this, but the place I've got to is that we need to be talking about this. We need to be talking to our teams about it. We need to be talking about how they're using it, making sure they're using it safely, and making sure people know when not to use it, because I think it's only a matter of time before people get hauled over the coals for the inappropriate use of AI. We need to use it mindfully. Just like we do, we don't get in the car for every single journey to the shop, do we? Not if we can avoid it. And we need to start looking at AI like that. It's a resource that we need to use with discretion. I would encourage people to go and play with the Microsoft Copilot if they haven't dabbled in it already. It's there, it's ready to use. It may just save you some time or help you in your day. All of the previous concerns aside, go and have a play with it, because if you don't know what we're talking about, then you're not going to be in the conversation really.
That's
over to you, Wendy.
Thank you, Ben. That's brilliant. So I'm just going through the chat box just for some comments, because I don't think you'd be able to see the chat box, and also a few more questions.
I'm scared to touch my screen, Wendy, in case.
Yeah, I know how you feel. So interesting from Terry Campbell. Pope Leo's recent encyclical letter, which is 120 pages long, but he says that in a time of artificial intelligence touched on many important points about best use of AI, for example, using it for improving communication rather than as a resource for non-reflective information. So you think about, the consequences and all the pitfalls. So that's quite a nice little thing to think about. Venus puts in the chat the latest ethical consumer guide on AI. So that's which comparing the environmental friendliness of the different options. So Katrina says, we don't yet have comprehensive guidance on what to advise patients with complex polypharmacy during heat waves. Is there any likelihood AI can safely help with this? For example, if you ask it to use pragmatic prescribing to reduce harm for older people with moderate severe frailty, that's just But I think, what's your view on that? And have you tried to do something like that? Well, you probably have, haven't you, with other resources?
So, you're talking about using AI to help rationalize prescribing and in frailty and elderly. Is that right?
Hi, Ben. Well,
Hello.
I was just really meaning from the point of view of, if somebody needs sick day rules, for example, at the moment we don't have an equivalent for people knowing the high rates of death and the likelihood that polypharmacy and the different medications which are contributing to that. I was just wondering, I think there's somebody doing something on this in the people who do all the emergency planning. But I'm just wondering whether, while we're waiting for guidance, because it's a pretty tricky situation for GPs to be in as a heat wave is within a day or two. Suddenly we know that there are all these people who are potentially taking tablets which could be making their lives more fragile.
See, do you mean, and I hope I haven't got you wrong here, but I'm sort of thinking of imagining myself in the next heat wave. Could be 2 weeks away, couldn't it? You were thinking maybe using AI to look across our clinical systems and identify at-risk patients and maybe do something proactive, like I guess message them all or something.
So there's already so Christelle Blunden has already done something. It's really good work where they find those people who are at risk. And then when they get messages through the Weather Health app, they send them messages. But I'm thinking more specifically about, because there's that list of medications that are in the government guidance about extreme heat that things like drugs which reduce sweating and diuretics and laxatives and all the rest of it. And, we're not going to be able to tell patients individually at the point of a heat wave what they should and shouldn't take. Whereas in advance, we do use sick day rules so that they know for those specific drugs what to use. So I was just wondering, in the absence of anything better, whether AI, because you mentioned medications, whether AI would be able to offer some advice on that, or whether it's just all, leave it all to clinical guidance, which we would hope, assume is safer.
Yeah, I actually think drugs is one of those things that AI's got huge potential to help with, because computers and AI, they like nice, firmly boundaried things, don't they? You can see that an AI could understand that this drug plus this drug plus this drug creates a certain risk and identify that and take a sort of a nice boundaried action, a nice defined action. No, I would be hopeful that actually we could see really good uses of AI in helping us with medicine prescribing, and as you say, heat waves and sick day rules and things like that in the future. Yeah, I think that's probably a really good potential use for the technology. But not yet.
So Andrew's put in the chat, which I didn't realize you could do this, that you can turn off the AI overview on your search engine unless you choose to use it. So thank you for that. Karen's has put out there, has anybody created a good use of AI to staff policy? No takers on that, so maybe not, but we'd love to have one of those, Karen, if you wanted to create one for us. That'd be very nice. Or anybody else. Somebody's saying, great presentation, Ben. What do you use to create your slides?
Yeah, happy to talk about that. So I hate writing PowerPoints. I love talking to people, but I absolutely hate writing PowerPoints. I just, the whole thing of sitting down PowerPoint just fills me with dread. So I use Claude, which is the large language model that I've used in my sort of personal non-NHS facing side. And I used Claude to build a PowerPoint for me. And what I do to do something like that is I have a long conversation with Claude about what I want to cover, what's going on. I kind of give it all my thoughts about stuff. And the whole process, does take time, but it will come up with a nice deck of slides that I then go and polish off and finish off myself. But it's definitely, I would say I don't know I think it saves me some time. I just hate PowerPoint. I just hate it. So anything, if I can get something else to write the PowerPoint for me.
That sounds good.
Yeah.
There's a couple of more comments from Vina about, looking for clinical information, that she uses MedWise rather than ChatGPT. And also, I think we learned about this yesterday. It was mentioned in Greener Practice meeting that Thora, THAURA, is supposed to be a more environmentally friendly model to use. What else? I love the analogy, as obviously as a pharmacist, I love the analogy of, the lowest effective dose. So you don't need to use the overcomplicated options for your choice of AI. So the medicines are an analogy with that. So that's all I think in the box. We've still got a few minutes left anyway. Does anybody want to take themselves off mute and say anything else? Kat Bristol has made a very good point about the use of Heidi. It can be really helpful for clinicians whose English isn't their first language. If it's their second or third language, it's good for that, I thought that was a really thoughtful point. But anyway, I think that's enough from me on the chat. Has anybody got anything else they want to say or that I have omitted? If so, apologies.
Hi. Yes, I've watched it sort of be rolling out. Obviously, I'm in this enviable position. I'm still doing GP locum, so I go around quite a lot of places to see how it's all coming together, and it's quite interesting. There's a few places I mentioned in the chat of like junior docs coming to me and say, "Oh, it's really great," and they were sort of using it for transcription, which I've started doing. I was slightly dubious, but it is, on the basis of these uni docs. So it amazingly takes time. And as they say, it does theoretically allow you to sit and listen rather than playing with the computer, right? So that's quite a good thing. But then one of them sort of mysteriously said, "Oh, sometimes we just get the old Chat GPT out and just if we're uncertain about a diagnosis and there's no supervisor around, we'll just whack it on and just to give us a differential diagnosis." And it's like, oh, which then sort of links into it that okay, there is a responsibility to the clinician of what you use it for. But of course, it can sort of lean into a position where the supervision is getting a little bit thin on the ground, and it sort of fills in the gaps for that kind of thing, which of course is not what it's designed for, but it may be an unexpected result kind of thing.
Kat, you've got your hands up. Would you like to?
Yes, what do you think, Ben? What I would really love to see is AI helping carers look at all the clients who need visits or what they need doing and planning the most efficient route that they can get round it all in the morning. Do you think it can do that?
Gosh, I've never thought about it. Probably, Kat. I can imagine it would need some sort of you're talking almost about getting into kind of telehealth, because I think there's scope for things like this to help. If patients have a degree of home monitoring, I don't know, how would you do it? Would you get your old people to maybe clock in the morning and say how they're doing, or if they've got an issue?
I think I was mainly just could they plan the route? They could just
plan the route. Yeah, plan
and
the route.
They'll know the
sure.
Traffic flows, and they'd know where the roads have been dug up.
They can do that already. Not even AI, just your simple Google Maps can do that. If you tell it, I'm going to these 5 places in order, it'll work out the quickest route for you. So yeah, computers can do it. I don't know if anyone's deployed it in the carer sphere yet.
Tree.
I do.
Well, I was just going to say, link to that. I'm on the clinical entrepreneur program for the NHS. And I was at their big thing on Monday where there were, I would say, the vast majority of the 250 cohort with new ideas is AI based or tech based stuff. And so, for example, next to me was somebody who is going to be trying to develop something which will be an AI phone call to patients with frailty who've recently been discharged from an MDT or from a frailty hub or whatever it might be, for example. And they're in the very early stages, but you can see there are lots of people wondering how they can do that. And I'm not sure. That for me, that feels a little bit too far down the road. I would think that somebody who's already got multiple problems would not want to be speaking to somebody with AI on the phone or who is an AI bot. But that's just me being old-fashioned, probably.
Being human, I'd say. Nick has put in the chat green PT, sustainable as a powerful AI that's sustainable. Respects your. So I don't know about that, greenpt.com, but that's something else to think about. And Ecosia as a search engine, which I know we use as our default in Gloucestershire. I'm going to read out Karen's rambling thoughts. Some interesting things to think about: using less graphics, using more blue and green, not red, to reduce carbon. The cost of use of AI to do presentations. Do we turn cameras off in webinars like this to reduce carbon? Small marginal gains. Be interesting to measure carbon use versus gain in wider projects. We find we get patients challenging us with the use of AI and our sustainability values. Karen's from Froome, in case anyone didn't know. And are starting to need good responses such as time gains, etc. So we probably need to wrap up now. Yeah, Rena, it feels like everyone is so into AI now that research or entrepreneurship in other things are being forgotten. Very good point. So thank you very much, Ben, and everybody else who's participated. A really, really interesting and really nice interactive session. And I've learnt loads, and I'm sure everybody else has as well. The recording will be available on the Greener Practice website very shortly, so you'll be able to share and look at it again. And if you would just have a little, just do the QR code for us and give us some feedback, we really, really appreciate that. So a brilliant presentation. Thank you very much. And thank you, everybody else. Have a good rest of the afternoon.
Thanks, Wendy. Thanks, everyone, for coming.
Thank you.